Intrapartum management of planned vaginal birth after previous cesarean delivery. What delivery setting is appropriate for conducting planned vaginal birth after previous cesarean delivery? Women should be advised that planned VBAC should be conducted in a suitably staffed and equipped delivery suite with continuous intrapartum care and monitoring with resources available for immediate cesarean delivery and advanced neonatal resuscitation. Women with an unplanned labor and history of previous cesarean delivery should have a discussion with an experienced obstetrician to determine feasibility of vaginal birth after previous cesarean delivery. Epidural analgesia is not contraindicated in a planned VBAC, although an increasing requirement for pain relief in labor should raise awareness of the possibility of an impending uterine rupture. Women should be advised to have continuous electronic fetal monitoring for the duration of planned VBAC, commencing at the onset of regular uterine contractions. There should be continuous monitoring of the labor to ensure prompt identification of maternal or fetal compromise, labor dystocia, or uterine scar rupture. Consequently, all women in established VBAC or vaginal birth after previous cesarean delivery labor should receive the following: supportive one-to-one care, intravenous access with full blood count and blood group and save, continuous electronic fetal monitoring, regular monitoring of maternal symptoms and signs, and regular no less than 4-hourly assessment of their cervicometric progress in labor. Most uterine ruptures, more than 90%, occur during labor, the peak incidence being at 4 to 5 centimeter cervical dilatation, with around 18% occurring in the second stage of labor and 8% being identified post-vaginal delivery. The clinical features associated with uterine scar rupture include abnormal CTG, 66 to 76%, severe abdominal pain, especially if persisting between contractions, acute onset scar tenderness, abnormal vaginal bleeding, hematuria, cessation of previously efficient uterine activity, maternal tachycardia, hypotension, fainting or shock, loss of station of the presenting part, and change in abdominal contour and inability to pick up fetal heart rate at the old transducer site. The risk of uterine rupture in an unscarred uterus is extremely rare at 2 per 10,000 or 0.02% deliveries, and this risk is mainly confined to multiparous women in labor. The risk of uterine rupture in planned vaginal birth after previous cesarean delivery is approximately 20 to 50 per 10,000 or 0.2 to 0.5%, and in elective repeat cesarean section, the risk is 2 per 10,000 or 0.02%. An observational study indicated a potential upper limit for non-hypoxic neonatal delivery of 18 minutes from suspected uterine rupture to delivery. It is important to note that scar dehiscence may be asymptomatic in up to 48% of women, and the classic triad of a complete uterine rupture that includes pain, vaginal bleeding, and fetal heart rate abnormalities may present in less than 10% of cases. How should women with a previous cesarean birth be advised in relation to induction or augmentation of labor? Women should be informed of the 2 to 3-fold increased risk of uterine rupture and around 1.5-fold increased risk of cesarean delivery in induced and/or augmented labor compared with spontaneous VBAC labor. A senior obstetrician should discuss the following with the woman: the decision to induce labor, the proposed method of induction, the decision to augment labor with oxytocin, the time intervals for serial vaginal examination, and the selected parameters of progress that would necessitate discontinuing VBAC. Clinicians should be aware that induction of labor using mechanical methods such as amniotomy or Foley catheter is associated with a lower risk of scar rupture compared with induction using prostaglandins. Prostaglandin induction compared with non-prostaglandin induction, for example amniotomy or intracervical Foley catheter, was associated with a higher uterine rupture risk, 87 per 10,000 or 0.87% versus 29 per 10,000 or 0.29%, and a higher risk of perinatal death due to uterine rupture, 11.2 per 10,000 or 0.11% versus 4.5 per 10,000 or 0.045%. Planning and conducting elective repeat cesarean section. What elements are involved in the perioperative, intraoperative, and postoperative care for elective repeat cesarean section? Elective repeat cesarean sections or ERCS delivery should be conducted after 39 plus 0 weeks of gestation. Antibiotics should be administered before making the skin incision in women undergoing elective repeat cesarean sections. All women undergoing elective repeat cesarean section or ERCS should receive thromboprophylaxis according to existing Royal College of Obstetricians and Gynecologists guidelines. Early recognition of placenta previa, adopting a multidisciplinary approach, and informed consent are important considerations in the management of women with placenta previa and previous cesarean delivery. Women considering elective repeat cesarean section or ERCS should be counseled that delaying delivery by 1 week from 38 plus 0 to 39 plus 0 weeks enables around a 5% reduction in the risk of respiratory morbidity, particularly reducing the risk of transient tachypnea of the newborn, but this delay may be associated with a 5 per 10,000 or 0.05% increase in the risk of antepartum stillbirth. Should there be a need to perform elective repeat cesarean section prior to 39 weeks, consideration should be given to administering maternal corticosteroids. Perioperative pre-incision antibiotics achieve a greater reduction in the risk of maternal infection than prophylactic antibiotics administered after making the skin incision. No detrimental effects on the baby have been demonstrated. Ideally, the chosen antibiotic should protect against endometritis and urinary tract and wound infections, for example, cefuroxime and metronidazole. How should women in special circumstances be cared for? Clinicians should be aware that there is uncertainty about the safety and efficacy of planned vaginal birth after previous cesarean delivery in pregnancies complicated by postdates, twin gestation, fetal macrosomia, antepartum stillbirth, or maternal age of 40 years or more. Hence, a cautious approach is advised if VBAC is being considered in such circumstances. Women who are preterm and considering the options for birth after a previous cesarean delivery should be informed that planned preterm vaginal birth after previous cesarean delivery has similar success rates to planned term vaginal birth after previous cesarean delivery, but with a lower risk of uterine rupture. 41 plus 0 weeks of gestation. The risk of stillbirth at or after 39 weeks is between 1.5 and twofold higher in women with previous cesarean delivery compared with women without previous cesarean delivery. A reasonable approach would be for women who plan vaginal birth after previous cesarean delivery to have a review by a senior obstetrician at 41 plus 0 weeks of gestation if spontaneous onset of labor has not ensued. Such a review should assess her likelihood of successful VBAC, for example, favorable cervix, previous vaginal birth, absence of any obstetric or fetal complications, her understanding of the increased maternal and perinatal risk if induction is chosen, her preference for membrane sweep, spontaneous vaginal birth after previous cesarean delivery, induced amniotomy or prostaglandin vaginal birth after previous cesarean delivery or elective repeat cesarean sections, and her future reproductive preferences. In practice, this may mean scheduling a provisional elective repeat cesarean sections at around 40 plus 10 weeks and converting to induction of labor, depending on further clinical and cervical assessment, at 40 plus 10 weeks. Tween gestation. Various studies have reported similar successful rates of vaginal birth after previous cesarean delivery in tween pregnancies, 45 to 84%, to those in singleton pregnancies. Suspected fetal macrosomia. For women with no prior vaginal delivery, undergoing vaginal birth after previous cesarean delivery labor when neonatal birth weight was 4 kilograms or higher, the VBAC success rate was reported as less than 50%, and the uterine rupture rate was 3.6%. Among women with previous cesarean delivery for dystocia, greater birth weight in the subsequent planned VBAC labor relative to the first birth weight was associated with a decreased likelihood of successful vaginal birth after previous cesarean delivery. However, third trimester ultrasound is a poor predictor of macrosomia in decision-making regarding vaginal birth after previous cesarean delivery. Antepartum stillbirth. Women with an antepartum stillbirth and a previous cesarean delivery undergo labor with a high vaginal birth after previous cesarean delivery success rate of 87%. Maternal age of 40 years or more. Maternal age of 40 years or more is an independent risk factor for stillbirth and unsuccessful vaginal birth after previous cesarean delivery. Preterm vaginal birth after previous cesarean delivery. The National Institute of Child Health and Human Development study showed planned VBAC success rates for preterm and term pregnancies were similar, 72.8% versus 73.3%. However, the rates of uterine rupture, 34 per 10,000 versus 74 per 10,000 respectively, and dehiscence, 26 per 10,000 versus 67 per 10,000 respectively, were significantly lower in preterm compared with term VBAC. Perinatal outcomes were similar with preterm VBAC and preterm ERCS. Appendix number 3. Clinical management of pregnant women who have had one or more cesarean birth or births.